Are we okay? Once again, thanks for the presentations. You know, it's very interesting. You're obviously the right people at the right place at the right time, and that's just wonderful. But in addition, your youth, somebody who's been at this a long time, your youth shows good promise for the future, and I think that's terrific for all of us. So thanks once again. Okay, we'll open this up for questions. We'll start with the panel members, and hopefully we'll go to the community members, others who are here for questions that the panelists or anybody else in the audience can answer. So let's go to the roundtable members first. Yes.
Ernestine Willis, the Medical College of Wisconsin. Thanks all of the panelists for crystal clear and remarkable examples of some of your experience that gets right at the community level. But Jesus, I wanted to know, in your volunteer population, do you have disciplines that include legal, since there's a lot of efforts on advocacy? And I understand that you're case management health, but one of the areas that I know I've worked with is that the issues of taking it to where the clients are is many times is very complex, and you got to use a more ecological approach. So specifically, I was wanting to know whether some of your volunteers legal experts.
That's a great question. We recently had a law clinic that was in partnership with St. Louis University and a law firm that would come to our clinic once a month to screen our patients for legal assistance problems or anything that we could do to help them. As a healthcare clinic, that's as much as we could do by simply providing the space and the opportunity for our patients to get the screening process that they needed. However, recently we have moved away from that partnership because a lot of our patients were reporting that they were coming in, getting the help that they needed, but it is a much more complicated process, and so it was sort of a waste of their time to see someone who would tell them this is what you need to do and this is the person you need to contact. So it was sort of putting an additional barrier. And so what we recommend is that the patients go directly to the legal assistance organizations, such as Legal Services of Eastern Missouri, for example, is one advocacy organization that we have in the region. That is a much easier and faster step. But there are significant barriers. For example, most law firms or legal assistance places, you have to call, and no one really picks up. It's more like leave a message and someone will call you back in English. Very few organizations have multi or bilingual options. So that's our experience. So we've moved away so that to keep away from the barriers.
Rob Logan, National Library of Medicine. First, Kari, hello. We exchange notes all the time, and we've never met. Let me back up one step and ask you all a common question. You've all talked eloquently about person-to-person efforts and person-to-group efforts and group-to-group efforts. I'm curious about your use of media. Has social media been helpful to you at all? Okay. Has any other forms of media been helpful to you in your work? And if so, what have you learned from?
We've actually found utilizing ethnic media was very helpful. So even when we started to do our workshops in education, first doing an ethnic media, let's say like kind of a little ad to post in the paper to show that it was actually legitimate. Because when we would go to the salons, people were, what it's free, what do you want from us? So having that was very helpful, and then to create the messaging that went out to the community so that they were hearing it. And so it was, we've also used mainstream media. We actually tried to utilize press conferences within each of the local areas to sort of capitalize on the local champions that we developed relationships with, to actually then also message out to a broader community about the importance of worker health.
For us, it's a little different. However, St. Louis is a much smaller area than the Oakland and San Francisco area. But when Casa originally was founded, the majority of the outreach was done at health fairs and mouth to mouth. And we recently, for the past 4 years, have no outreach person or someone responsible for outreach. So the majority of our client referrals or patient referrals is done by friends and family, which is something very unique to our Hispanic and Latino community. We are now struggling to get that outreach to the other foreign-born communities in St. Louis. So we've recently redeveloped our website and redeveloped our Facebook so that people can call from Facebook or request an appointment directly from Facebook. So that's our only social media experience, and then very, very little mainstream media. But that's, I think, unique for our city.
It was a good question, Rob. For our workshops, we don't usually promote them on social media, and one of the reasons why is depending on the organization, they have a better way of reaching the people that they need to reach to bring in. And it's also, the workshops are held like in a trusted setting, so a place that they're already comfortable going. And so we really leave that, the majority of recruiting participants or reaching out about the different workshops up to the organizations. We do use social media in other instances though.
As far as our clinic goes, I used to be afraid that the hospital administration was going to find out about it, and they were going to be like, this clinic has an RVU deficiency. What do you mean this doctor sees one patient in a half day, you know? Our administration changed a little while ago, and our current hospital administration is extremely supportive of the work of the clinic, which I'm incredibly grateful for. Now my worry is more about the issues that were coming up in the first panel, right, about the potential for creating repositories of specific information about individuals that might subsequently be used to harm them. So I don't know what to do at this point.
Alicia Fernandez, UCSF and San Francisco General. I want to thank all the panelists. I do have a question for you, Julia. I have several Vietnamese patients who work in hair salons, and thank you so much for the incredible work you've done. The model of I don't even know what to call it, community organizing that you've done through Asian Health Services is really unique. And even progressive places like San Francisco General, we have maybe community health workers, or we may have navigators. We don't have anything that duplicates, to my knowledge, that duplicates the sort of work that you have been able to do. And I'm wondering if you could speak to how your position is funded and how this work that you were doing was being supported, and how the healthcare center, how Asian Health Services saw this position and saw the work that you were doing, and how does it fit into their strategic view?
Yeah, that's a great question. Well, because our organization has always seen advocacy as extremely key, there was a commitment to this particular issue, and we were able to get grant funding initially for this and been able to support it through other foundations and also other kind of federal grants through trainings and education. So, and for the positions, because we were able to generate enough momentum and then also impacted some of our patients who are working in the nail salon industry, we had a commitment at the leadership to be able to do that. So it is funded by other grants, and there had to be a commitment to be able to look for them and create that space. And it is hard because there's so many different issues, but I think that this was such a prevalent one that we just couldn't ignore it, and knew that something had to be done beyond our clinical walls. So it really did require leadership commitment at the highest level. So.
Julie, has any of that been done outside the San Francisco Bay Area?
You know, I know that we've been in touch with, there is a coalition in Seattle through King County. They started working together, but based on sort of a regulatory agency model. And I know that there are some other smaller groups that have been doing this. So we've been trying to collectively reach out and connect with everyone to kind of help move things forward, but not to my knowledge in terms of specifically on salon worker health.
So, Nick, Hey, Ruth Parker. Nick, I have one question for you, and then I have one I want to just ask everyone quickly. So my question's about the Human Rights Clinic and the language that you're using to call the clinic that. That's not a term I'm familiar with, as in an association of human rights clinics, and I'm just wondering about how that language helps or hurts what you're doing, you know, and sort of thinking about what we call services and where they are and whether or not they flip, blah, 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 blah. You're sitting in the middle of it. So that's a question to you. To each of you, I'd like to know from where you are and what you're doing, I'd like to know if you have specific requests of those who are involved at the academies with health literacy, of specific areas for engagement or action.
In terms of what you call stuff, when you're, as I am, involved in immigration trials as an expert witness, it's important to maintain objectivity and have that be a public aspect of your work. So one thing that's happened to me in cross-examination occasionally is government attorneys will say, well, you work in this human rights clinic, so clearly you're a partisan and you're dedicated to bringing immigrants into the country, so how can we trust your testimony, right? That said, I think, you know, where the name of our clinic comes from is it's named sort of in harmony with a national organization called Physicians for Human Rights that provides forensic evaluations through a trained network of volunteers. And I think the way that they would put it and the way I put it is like, so the fact that I work in an emergency room doesn't make me partisan in diagnosing people with pneumonia. I diagnose people with pneumonia when they have pneumonia, you know? And if someone's a traumatized refugee, I diagnose their PTSD, and if they don't have PTSD, I don't diagnose it. So I think that you bring up an important point that increasingly we're going to have to be careful if we're planning on using expert judgment and the trappings that go with it to also be responsible to the obligation of objectivity and reflect that in our language. I'm not sure if that's what you were getting at, but. And then in terms of the magic wand stuff, I mean, you know, my sense is that what clinicians need is more and broader education, even at the medical school level and in the residency level, about the kind of issues that I was raising. But I think the sorts of programs that the other three panelists have discussed are an excellent example of how that can be enacted practically with the populations who we're serving primarily. But these are also really important educational opportunities for clinicians in training. So I would love to have my residents rotate through all of these programs.
Thanks, Ruth. I can't think of a request right now, but I will definitely give that some thought. So thank you.
I feel like I have a general idea of what the National Academy does. So if I maybe understood a little more, I could respond. But just on kind of the first level response, really maybe related to clinicians, we have developed like a screening tool for clinicians for if you have a patient who works in the industry, to kind of how to screen and then provide tips, and then we have materials. So to be able to, you know, distribute and get word out about that, that would be very helpful.
I guess something I haven't really heard today is a discussion of integration of mental health and physical health. And at least in St. Louis, there is a lot of conversation and discussion about the integration of mental health. But since we are here for immigrants and refugees, there's little conversation regarding integration of physical health and mental health. A lot of our patients do go through very traumatic experiences on their way to St. Louis or other parts of the nation. So I think a more detailed discussion and funding opportunities for nonprofits that are in a unique position to address that. For example, Casa is right now in the process of seeking funding up to $1 million to renovate the building next door, to build a mental health collaborative where we will be sort of harboring social workers, psychologists in training that come to St. Louis University, Washington University in St. Louis, Webster, where they will be receiving their training and their practicums, and they'll be seeing our patients for $10 per session, and they'll be basically volunteers under the supervision of a therapist. And so that's something I would like to hear more about.
Michael, and then I am going to open it up to any of the public members who would like to ask a question.
Thank you. Michael Valaire, Institute for Healthcare Advancement. First of all, you guys these are all very incredible programs. Thank you for sharing all the things that you do. And health literacy is sort of a secondary step. I think your first step is that trust and engagement, because you can't get to health literacy until you have the trust and the engagement among the people with whom you work and who you serve. Could each of you talk a little bit about the challenges of earning that trust, bringing those people into your programs and engaging with them? Where are some of those threats, and what sort of advocacy do you use in terms of individuals or groups trusted within the community to help bridge your activities to the recipients of who actually gets those services? How do you sort of go about doing that, and what are some of your challenges and what are some of your successes in that area?
I guess I can quickly just further elaborate what I was discussing about financial assistance. The majority of our patients that are undocumented do not have access to public assistance programs and therefore no access to insurance or may not be able to afford it. And so the majority of our advocacy is spent on cases where patients need procedures that are medically recommended, sometimes medically necessary, and administrators at healthcare organizations have policies in place in accordance to the law and the auditing process by the IRS. And so there are a lot of parties that need to be in communication and in agreement. And so when we have patients that are recommended to get their medically necessary treatment, we face a lot of barriers in scheduling it because we have to please the auditory process, et cetera, or the auditing process. So the type of advocacy that we engage in is a lot of, so is this patient being denied care? If so, we would like to see that in writing. And that usually budges the boat. So that's an example, but there are many, many others, and we could be talking all day.
For us, when we started outreaching to the salon worker population, it was very difficult because when we started talking about health, I think a lot of workers and even the owners themselves, who often work alongside with their workers, felt like, are you going to put us out of business? Because is this something it sounds scary? And then if customers like say, oh, well, gosh, if I'm wearing a mask or gloves, that's going to make our environment look really scary. So I think there was a lot of heightened anxiety about that. And so I think in that sense, what we had to do was, again, we had to relate to where they were at. And we actually would start off by having some initial workshops, but we made them fun. And so they weren't framed as you're coming to a health workshop. It's a community gathering, come meet other folks in the community, had like a Lunar New Year kind of celebration, and then we started, infusing some ideas about health. And then I think I mentioned when we were doing community forums, folks actually weren't focused on health. They were really about, okay, I want to keep my livelihood. How do I stay in this? What are my financial, what are my legal, everything else. And so we had to attend to that first in many ways. So that's how we started building trust. With our patients, it was easier because they knew us and we've been an institution. And we did bring in other groups that interfaced with social services, with the salon worker population in that sense. So we then started bridging relationships with those organizations. So we did a dual process in that sense.
For us, our trust actually really first begins with the community organizations. And so we develop those relationships with the community organizations. They know that they can trust us to get workshop materials to them on time, that will respond to their questions, that will work together to develop a great workshop. Because the refugees and immigrants already have a trusted relationship with them. So for us, first is with the organizations. And then once we're in the workshops, it's always interesting the feeling at the beginning of a workshop versus at the end. Because at the beginning, it's so distant and people don't know what you're really going to say or what you're going to ask of them. And then as the workshop develops, it just becomes so much more open, and it's really during that workshop that you can gain their trust, that they can feel comfortable to ask the questions that they have or to share the stories that they would like to share.
Yeah, I kind of echo that and say the community, the liaison with the community organizations is, we couldn't survive without it. We take forensic referrals. We also take referrals just for complicated, traumatized, medically complex, decompensated PTSD patients. And the only reason those people come and see me is because Mike told them to come see me, or Haragu told them to come see me, or whoever. And when I ask them why they're here, they usually say because Mike said I should come here. So the community organizations are where the magic happens for us. The other thing that I'd say is that we have. So we have really great interpreter services at Highland. We have an interpreter who's from Eritrea who speaks Tigrinya, Amharic, Arabic, Italian, and English. So when he dies, we're going to have to hire 4 or 5 new people. He's a cultural ambassador. He's not just an interpreter. So he will stop me in the middle of a conversation and explain something that I'm totally failing to understand about Orthodox Christianity in Eritrea that's vital to what we're talking about. When a patient of mine is having trouble getting a medication from the pharmacy, I know about it because he sends me an email. Whereas for our mom-speaking indigenous Guatemalan patients, we don't have any interpreters. And so those people are, the project of building rapport with them and of getting their trust and maintaining it is so much harder than it is in a situation where you've got someone within a system who's a sort of designated cultural ambassador. So, yeah.
So I'm going to take a few moments. Thanks very much for all those answers. I'm going to take a few minutes from lunch to see if there's a question or two from the public, and I see that there is.
Hi. Hello? Is it on? Okay, great. Umair Shah, I'm the Executive Director down at Harris County Public Health in Houston, Texas, and I'm a committee member, and apologies that I got off a flight a little bit late, but I'm here, so I'm excited to be here. I actually had and I missed some of the presentation, so I apologize if this was already covered. We run a refugee health clinic and as part of our health department down in Houston, again, the county health department. And the question I have for you is that oftentimes these clinics actually turn out to be de facto community centers, gathering spots, opportunities for doing a lot more than just medical health and really that engagement piece of really how do you work with an overall community and really empowering that community. How do you see that role beyond just the 4 walls of the clinic, but really the gathering spot, that focal point for really ensuring that communities of refugees and immigrants are stronger and more connected, especially in today's day and age? Thank you.
That's a really great question. I'm leaving this meeting early to go to a meeting with the refugee clinic within Highland to try to figure out how we do exactly that, so I'm going to get back to you in about 6 months. But in general, that's what I see being so great about our community organizations that mainly do legal advocacy, but also do case management services or psychological care for discrete populations, and even individual immigration attorneys. Like around here, we have individual immigration attorneys who specialize in mom-speaking Guatemalans or who specialize in Eritrean FGM cases, and those places focus, really serve as these vital nuclei for those communities. And I should explain, this is a bizarre contingency of Alameda County, but our human rights clinic, which serves asylum seekers, is completely administratively separated from our refugee clinic, which does federally mandated newcomer screening. So those are the people that I'm talking to later today to try to further integrate those services. But for now, those are siloed in this county, which is disastrous because it prevents exactly the kind of thing that you're talking about. So.
Hello, everyone. My name is Imelda Plasencia, and I'm with the Latino Coalition for a Healthy California. I have 2 questions considering the threat of immigrant lives and undocumented people in the United States. So some context, immigration enforcement has increased by 10,000 agents in the United States. Border Patrol has increased by 5,000 agents. And so just a lot of threats overall. I'm wondering how that's affecting usage and enrollment of services within your clinic. Here in California, we've heard a lot of people intentionally going in and disenrolling or not attending. I know folks provided a lot of examples already, but comprehensively, how is it impacting, and what are the clinics doing to be able to address that and assure some sense of security? And my second question is, clinics are really, there is a nice memo that is more of a guideline that states that healthcare facilities are sensitive locations for conducting enforcement, but there is no policy that does restrict immigration agents from entering clinics. Have heard some clinics that are responding by being able to kind of organize what to do if ICE agents were to come into the healthcare facility. So I'm wondering if you're all having conversations of that as well, especially in other states. Thank you.
Anyone want to start that, or should I? Local community clinics are way ahead of, well, I should watch what I say, but a lot of our local community clinics, FQHCs, have done a really fantastic job of moving very swiftly on this, including La Clinica, I gather Asian Health Services, although I don't know a lot about those efforts, and UCSF as well has done a good job of responding to this. What most people are doing right now is developing clear policies about who's allowed where, what's a restricted area, and what's not, and trying to train staff in how to respond to legal, semi-legal, or frankly illegal incursions by immigration enforcement officials. So we're doing that kind of stuff as well. I'll pass it on.
I'm not sure from a clinic standpoint, but just what I had mentioned earlier as far as an organizational standpoint, just that given the circumstances now, refugee organizations really have to prioritize what they can work on and what are their most important, what are the refugees' most important needs right at this moment. So seeing some changes in that respect from an organizational perspective.
At Asian Health Services, we have been developing policies around the private space issue, and so I think to your point about creating, claiming that the waiting room is a private space, and we have been conducting trainings with our staff from local legal organizations around this issue of what and how managers can respond, like if they are faced with, let's say, someone from ICE. And we've also have definitely had patients who have a high level of anxiety, who actually say, I want to get off of Medi-Cal right now. I don't, even though it may not be warranted. And so we've been trying to articulate, please seek the services that you need at this point. And we are also developing kind of a role play for our providers too, because we've also had a lot of patients who are asking questions of what they should do. So we're in the process of developing that literally this week.
As of January 2nd, Casa has a policy in accordance to the law to either fully collaborate as needed with agents. So it's just to further echo what my colleagues here have mentioned. We already have a policy in place. Our staff has been trained. And if we have to collaborate, that's what we'll do.
So I want to thank you all for your contributions. Seeing no more questions from the audience. And I want to thank Dresney for keeping us on time. So we'll break for lunch, and we'll be back here promptly at 1:30. There are a list of restaurants and other eateries that we were given or is available, so please make use of that. Enjoy your lunch, and we hope to see everybody back at 1:30 promptly. Thanks very much.